Question 1. We have a pregnant patient at term with an active genital herpes infection. Regardless of her obstetric history, an active lesion makes vaginal delivery unsafe due to high viral transmission risk. You must proceed with an elective lower segment cesarean section. In maternal infections, the safest route is dictated entirely by the immediate risk to the fetus at the exact moment of birth. Question 2 asks for the hyperthyroidism drug of choice at exactly 8 weeks of gestation. Drug safety profiles are trimester-dependent. Methimazole is associated with fetal scalp defects, specifically aplasia cutis, during the first trimester. This makes propylthiouracil, or PTU, the mandatory choice until the patient reaches the second trimester. Examine question 3. A woman at 37 weeks gestation is taking warfarin for prosthetic valves. Warfarin is a teratogen, causing severe cartilage defects, but mechanical heart valves represent the only strict exception where its use is permitted through mid-pregnancy. Stop and think for a second. Why does the protocol require us to forcefully discontinue warfarin at exactly 36 weeks, well before labor actually begins? Warfarin crosses the placenta. If the fetus remains anticoagulated during the physical trauma of labor, they face a high risk of intracranial hemorrhage. To prevent this, we switch to low molecular weight heparin at 36 weeks, as its molecules are too large to cross. Managing high-risk pharmacology requires clinicians to proactively anticipate the physical stress of delivery weeks in advance. In question 4, an 18-week patient has biochemical screening results showing a high risk of neural tube defects, marked by an elevated AFP level. Avoid the common instinct to jump straight to invasive diagnostic testing like amniocentesis. The immediate next step is the least invasive option, a level 2 anomaly scan. This allows the clinician to physically visualize the anatomy and confirm the location of the defect before proceeding. Diagnostic algorithms prioritize minimizing fetal risk, requiring visual confirmation before escalating to procedures involving needles. Our final problem, question 5, tests your recall of biochemical nomenclature. We need to identify the incorrect option for the quadruple marker test. The quadruple test measures AFP, beta-HCG, unconjugated estriol, and inhibin A. Examiners often use inhibin B as a trap. Because the test specifically requires inhibin A, option A is the incorrect component and the correct answer to the question. Here are the core protocols to memorize. Active herpes at term requires an LSCS. T1 hyperthyroidism requires PTU. Warfarin must be swapped for heparin at 36 weeks. High AFP levels lead to an ultrasound, and the quad test uses inhibin A. Mastering these MCQs is about merging precise terminology with a firm grasp of the dynamic gestational timeline.